Welcome to the presentation for Nursing 150 Module 4. This presentation will cover osteoarthritis, rheumatoid arthritis, and gout. The majority of this information can also be found in Chapter 20 of your IGGI book. Okay, this is the definition of osteoarthritis: progressive deterioration and loss of cartilage in one or more joints. Keywords with osteoarthritis, one of the keywords is definitely deterioration. Deterioration of the bone, or I'm sorry, not the bone, the joint. And it's essentially due to increased age, increased use of the joint. So people who are at risk for having this occur, people who are older, people who use their joints more. So in the next slide, we'll actually talk about the different types, the primary and secondary types. But like I said, the key word here is deterioration. For osteoarthritis, the second key word is localized, which I don't know if it's in this slide, but a key word for osteoarthritis is localized. So it's localized to a specific joint. It could be one or more joints, but it's localized to the joint itself. So localized, it's deterioration. It's non-inflammatory in cause. It can become an inflammatory situation, but initially it's not an inflammatory process that starts this. It's a deterioration that starts this process. This picture kind of just depicts the pathophysiology of osteoarthritis. You can review this in your book, The Pathophysiology of It. You don't have to memorize it, but essentially what happens is the joint, for multiple reasons, is just, it's overused and it breaks down. There's lots of different pieces as far as pathophysiology of all this. The synovial fluid breaks down. A lot of this occurs as we grow older because of the loss of fluid. There should be a certain amount of fluid in here that lubricates the joint and keeps the joint moving nice and smoothly. But as we grow older, our body produces less water, and we usually have less water available. And so it's kind of just a process of aging at times. There are certain things that we have in our life that increase this process or fast forward this process, such as movement, increased weight that we put on these joints. Some occupations will put an increased workload on these joints and cause this process to fast forward. Basically, what ultimately happens is this joint degenerates, and it causes pain because now the joint does not have its secreting fluid to make it move in a nice, smooth movement. I don't want you to get too caught up in the pathophysiology of this, but essentially what you need to understand is there is a degeneration of the joint. And sometimes what happens is there are pieces of this little cartilage break off, and there's little pieces in there. And that's what makes that noise when people, you'll hear people when they move their knee. Typically it's a knee, I've heard a lot. It sounds like crunchy in there. It's called crepitus. And that's because parts of the cartilage starts to degenerate and just is kind of just hanging out, floating around in there. There's a good picture of this on page 319 in your book. The cartilage particles floating around in there that will cause that noise called crepitus. It's kind of like a grating sound caused by loosened bone and cartilage in that joint. Primary causes of osteoarthritis is usually a combination of many factors. Typically it's aging. Obesity can cause it, and obesity causes it because it's more pressure on that joint. Smoking tends to increase the people's risk factors for osteoarthritis. A lot of it is because the fluid factor and decreased blood flow to the areas. Secondary causes are typically due to other problems when they're secondary to another problem, like if there's a trauma, someone has had a big injury in a joint, like a knee, injured in an accident, that can increase the risk of getting a degeneration in that joint. Occupations, I already kind of mentioned before, is a secondary cause of osteoarthritis. What always comes to mind when I think of this is like a baseball catcher. Somebody who has been a baseball catcher and they bend a lot over and over and over and over again, they tend to get bad knees and degeneration in their knee joints from the overuse of it. There's thought to be a genetic link to osteoarthritis. There's some studies that show that there is some kind of a genetic link that puts you more at risk. Typical joints that are affected by this is your knees, back, your hips. And if you think about this, these are the big joints that bear the brunt of the weight of our body, and they typically are what's doing a lot of the work whenever we're doing out and about. Your knees, your hips, and your back is where a lot of the weight is kind of put when you're standing upright. So those are the most common joints that are affected by osteoarthritis. All right, talking about physical assessment and labs for a patient with osteoarthritis. Chronic pain is one of the most frequent complaints assessment that you'll find with a patient with osteoarthritis. It's usually early on in the disease process. They will say that they have pain with increased activity that pretty much stops when they rest. Later on in the disease process, it just hurts all the time, even if they are resting. So that's going to be the big thing. They're going to say they have chronic pain. And then thinking about kind of making that definitive diagnosis, where's the pain? Oh, it's in my right knee all the time. What do you do for a living is your next question. You know, if it's somebody that says, oh, I'm a carpet layer, I'm down on my knees a lot, could kind of point you in the direction of osteoarthritis. Again, because it's localized, they have a occupation that would put them at risk for an osteoarthritis in the knee. So just kind of thinking like a nurse there on how you would kind of differentiate this. As far as labs, the ESR, which is the erythrocyte sedimentation rate, could indicate some osteoarthritis. And remember, we said it's not an inflammatory process. However, as the disease process continues, it can become inflammatory because sometimes the synovial sac in there can get inflamed. So that's that synovial sac that's there that provides the fluid to lubricate the joint. Sometimes that area becomes inflamed as secondary to osteoarthritis, which is a degeneration of the joint. So you may see an elevated ESR on these patients. X-rays is going to be more of a definitive test to determine if they have osteoarthritis or not, because on some joints in an X-ray you can see the deformity of the joint. Some require an MRI, like backs. People with back osteoarthritis, sometimes an MRI is a more definitive way to see it. So ESR, X-rays, and MRI all together is going to help us look to determine if somebody has an osteoarthritis. As far as treatment, you always have your non-pharmacologic, your pharmacologic, and then there's surgical possibilities for somebody. Non-pharmacologic treatment is going to focus on the pain, trying to treat that patient's pain. And it's things like applying heat and cold. And remember your safety tips as far as helping a patient apply heat or cold to an area. So the joint is no different. You always want to make sure it's 20 on, 20 off. And make sure that you're using safety mechanisms so that the patient does not have an injury related to applying heat or cold to an area. So that means that you don't lay the heat or cold directly on the skin. You make sure there's a layer to protect the skin. And just make sure that they don't turn it on, the heating pad, and then fall asleep or something like that, because they're going to have an injury from that. So think of all your safety things that you would need to teach a patient regarding applying heat and cold. Other non-pharmacologic therapies for a patient with the osteoarthritis, that's going to consist of, there's braces that can kind of provide a support for that joint. This is going to be up to a doctor to determine whether that's going to be effective or not. Weight control. If somebody's obese and there's a lot of pressure being placed on these joints, then perhaps just even losing weight could actually decrease some of the pressure on that joint and decrease the amount of pain that they're having. Pharmacologic care of a patient with osteoarthritis. We're going to start out, the first line of medication for a patient with osteoarthritis is Tylenol. Tylenol is an analgesic. Remember, these patients are not having an inflammatory process, so and first line is more of an analgesic rather than a anti-inflammatory medication. So we're going to start out with Tylenol. Thing about Tylenol, you always have to be safe with Tylenol. They cannot have more than 4,000 milligrams a day, especially if they have any kind of pre-comorbidity of having liver disease. So you have to be careful with Tylenol because it can damage the liver, and they don't want to be taking more than 4,000 milligrams a day. Lidocaine patches is another pharmacologic way that we can approach pain control. Those lidocaine patches, they'll place right directly on the joint. They can change it out 3 times a day. They can put as many as 3 patches on one joint. It's pretty easy to use. The only thing I do know about lidocaine patches, they are expensive. So it might be a little bit difficult for some people to use them. They can cause some skin irritation too, but that's just people who are maybe a little bit hypersensitive. You can move on to the non-steroidal anti-inflammatory medications like the NSAIDs. If somebody has developed a disease process that probably is looking like they have a synovitis, which is an inflammation of that synovial fluid, that synovial sac, it could help with their pain control. Flexeril, or a muscle relaxant, could be another drug of choice for a patient. And basically what it does is it decreases skeletal muscle, so that could be an adjunct to like a Tylenol in order to help with pain control. Muscle relaxants, there are some safety things that you have to know to monitor. Also, they need to monitor their liver functions with these medications as well. These medications can also cause people to be sleepy. So if they're trying to be functional and go to work and have pain control, they might not maybe just consider taking the muscle relaxant at night, because sometimes these can make them a little bit too drowsy in order to be able to function. So all of these medications come with some possible side effects. Of course, probably with Tylenol, it's going to be a liver monitoring. We know with NSAIDs, they go to the NSAIDs because their disease progress has progressed to an inflammatory issue, we know we have to have that. We have to monitor for that GI upset, those black tarry stools. With muscle relaxants, another issues with that is it's going to make them sleepy. And then there's also the liver issue with that one. Now, these patients can progress so much that we are not unable to control their pain with all of these things. So we are going to have to go to surgery. It's a possibility. And basically, if the joint is so degenerative, they can actually take them in and they can replace their joint with a fake one, which we have made lots and lots of advances in the past 10 years or so. Thus, the new Spine Joint Center at the hospital that we are affiliated with. So, usually a successful surgery, and basically just think about, as you read through the chapter, about nursing care for someone who just had maybe a knee replacement or a hip replacement. So some of those top things as far as nursing care for a patient who has just possibly had like a total joint replacement. Indications for this surgery is just the pain and mobility. So if somebody has just gotten to the point where they have had so much pain and they have so much decreased mobility, they're going to go to surgery. Postoperatively, infection, mobility, DVT prophylaxis. Those are a lot of the roles of the nurse. Pain control. DVT prophylaxis is going to be controlled with Lovenox and heparin. Those are anticoagulants. Typically, it's a subcutaneous injection that they're going to get to keep their blood thin so that they don't get clots and that travel and can cause major complications. Mobility is going to be working with PT/OT and making sure that they are up and moving as directed by the physician. Page 326 talks about the patient recovering from hip surgery, from a hip replacement. So make sure you kind of review that nursing care of a patient that's going through these surgeries. Chart 22 specifically on page 326 talks about the postoperative care of the older adult with a total hip arthroplasty. So think about what that means to you as a nurse taking care of one of those patients. A lot of the nursing care postoperatively with a hip patient is going to be making sure that they keep that hip in line and it follows the guidelines as directed by the surgeon. There's also on page 327, chart 23, care of the patients with total hip arthroplasty after hospital discharge, talking about the things that you would talk to your patient about, like not sitting for prolonged periods, don't cross their legs, don't bend the hips more than a 90 degree, pain management, making sure they're taking their medications as prescribed, making sure that they get enough rest. Other care is going to be walking as, they're going to be up and moving. They're going to be encouraged to continue to ambulate within the guidelines given to them. And then report any signs or symptoms of infection as well. It's going to be some major things that we're going to talk to the patient about. Going back to physical assessment just for a moment, I do want to bring up that something called Borchards nodes or Herberdin's nodes. These are when the joints of the hand are affected with osteoarthritis, because that is commonly affected as well because we use our hands a lot, and it's usually people who work with their hands on a daily basis that can get this, and it's a degeneration of the joints of the hands related, to that constant movement. So Borchards is the proximal hand, which means the knuckles closest to, say, your wrist. So it's at the base of your fingers, those nodes. And it's not, you've probably seen patients who have deformities related to rheumatoid arthritis. These are different. These are just nodules. So basically what it does is make their knuckles look really big. The Herberdin's nodes are the most distal bend joint in your fingers is what that's referring to. So it's the very tips, the joints right at the very tips of your fingers. The way I remember this is B comes before H, so B is the most proximal to your wrist, and then H is the distal to your wrist. And last but not least for this slide, I want to mention Glucosamine Chondroitin. Glucosamine with a mixture and chondroitin are natural supplements that have been found to be helpful in a patient's pain control with osteoarthritis. Glucosamine is thought to decrease inflammation. Chondroitin is thought to strengthen cartilage. As with any natural supplement, they want to ask their physician if it's something they should be taking, if the benefits outweigh the risk. And always with any natural supplement, the patient needs to let their physician know that they're taking it and make sure it's safe to take with all their other medications and treatments. Page 323 in IGGI, chart 20-1, talks about patient and family education related to taking glucosamine supplements. Basically, they just need to tell their provider they shouldn't take it if they have high blood pressure, which is a little common among a lot of our patients, so we have to be careful with that. It also can affect blood sugar. Anybody breastfeeding should not be taking it. But you should just make sure you review that table so you have an understanding of how it actually can be helpful. It's been found to be very helpful. The thing about it, though, they do have to take it for about 6 months before they see the full effect of it. So some people start taking it and they don't think it's helpful, so they'll quit. But you have to be able to take it for a certain amount of time to be able to determine whether it's going to help you or not. The other thing with glucosamine, if you've ever looked at them at the drugstore, if you ever, looking at the vitamin supplement area, glucosamine is a huge tablet typically. I haven't been able to find them very small tabs, so they're kind of hard to swallow, so it can be a little bit difficult for some patients to take them, but it can work in some instances. Okay, moving on to rheumatoid arthritis. Key words here for rheumatoid arthritis. Basically, this is an inflammatory process. It's a systemic inflammatory process. If you compare that to osteoarthritis, you will remember that it was localized and it was non-inflammatory. It was more of a degenerative arthritis. So, differences between rheumatoid arthritis and osteoarthritis. Rheumatoid is a systemic and it's an inflammatory process. It is a disease of the connective tissue. The other big thing about rheumatoid arthritis, or RA, is that it is thought to be an autoimmune process. So it is that process where the body determines that it recognizes something that is not part of its own, and so it causes an inflammatory process that eventually leads to a destruction of connective tissue and synovial membrane within the joints. It weakens the joint over time and can lead to a dislocation and permanent deformity of the joint. So this is the disease where you're going to see a lot more deformities in the joint. In osteoarthritis, you're going to see some swelling, possibly some, like I said, swollen looking joints, maybe of the fingers, maybe the knee joint can be swollen. In rheumatoid arthritis, it's going to be more of a deformity, so it's going to look more deformed, and we'll have some pictures of that coming up too. So basically, the disease process of rheumatoid arthritis is an autoimmune process that attacks the synovial membrane within the joints and the connective tissue and causes it just breaks it down, and it can cause a deformed, dislocated joint. This disease process is like most autoimmune things. Autoimmune disease processes can vary from person to person. It can be progressive and fast-moving in some. It can be slow to progress in others and less severe. So again, this just is a continuation of the definition of rheumatoid arthritis. You can review the specific pathophysiology. It's not something you need to memorize, but it's always a good idea to review that because it helps you understand the disease process and helps you understand the signs and symptoms that the patient is presenting with. And it also will help you understand the treatment for it. Like I said, this is a systemic disease, so it can affect other areas of the body. It typically affects the synovial joints, though. And again, this is how it differs from osteoarthritis. Osteo could be localized to one joint. Somebody has RA, they're most likely going to have it like in both hands, as opposed to just having it in one hand. This is just a picture of the deformed joint that you might see with a patient with rheumatoid arthritis, just where those muscles weaken and it causes more of a deformity, as opposed to like an osteo where you might just see an enlarged joint. The cause of rheumatoid arthritis is essentially unknown. Again, it's like those autoimmune disorders that we don't know what causes them. There's thought to be a genetic link or an environmental link, but has not been proven. Signs and symptoms of rheumatoid arthritis. Typically, the first signs is joint stiffness, swelling, pain to the joints. The kind of a hallmark sign of rheumatoid arthritis is morning stiffness. And it's typically morning stiffness lasting longer than 30 minutes. Moderate to severe pain as well. Joint deformities will start to be clear. The muscles will start to decrease and atrophy. And then basically the patient will start to have decreased range of motion in the affected joints. And as opposed to osteoarthritis, they will start having a spongy, soft feeling in the joint as opposed to like that crepitus sound. These patients can also have a low-grade temp, and that's because of that systemic autoimmune process, that inflammatory process. So they actually can get, they can start to lose weight, have decreased appetite, get anemic, basically, and that's in response to the inflammatory response that is going on in their body. They will absolutely have an elevated ESR, the erythrocyte sedimentation rate, and they'll also have something called a positive rheumatoid factor. That is a very specific lab test that can check for rheumatoid arthritis. There are some other things that can cause an elevation in a rheumatoid factor. But basically what it's testing for is some antibodies that the body has built up in response to this connective tissue disease. Most patients with rheumatoid arthritis have a positive titer for the rheumatoid factor. X-ray can also be utilized in the assessment and diagnosis of rheumatoid arthritis. They'll look to see if they can see joint changes. Something called an arthrocentesis is also an invasive procedure that could be used for the definitive diagnosis. If a patient has a particularly swollen joint, particularly disfigured joint, they might have an excess of the synovial fluid built up, and they can pull off that fluid and they'll send it to be checked for any kind of inflammatory cells and or immune complexes. They'll actually check it for the rheumatoid factor. They'll check it for elevated white blood cells, cloudiness, and volume. So that's a little bit of invasive, and that would be, you as the nurse are going to help prepare them, get a signed consent for that test, and they're going to monitor that site for 24 hours post-procedure just because they're going to stick a needle in their joint and it can be painful. So they're going to elevate it, put some ice on it, and just monitor it for any signs and symptoms of infection. Also, they can continue on and do a bone scanner, joint scanner, and MRI just for a more definitive diagnosis. Also note on page 336, chart 28 is the laboratory profile in relation to connective tissue disease labs. Specifically, rheumatoid factor and ANA total are listed there regarding, and those are related to the diagnosis of rheumatoid arthritis. Treatment for patient with rheumatoid arthritis. So the goal of treatment for a patient with rheumatoid arthritis is going to consist of anti-inflammatory meds because it is an inflammatory process. We are also going to give them some of those autoimmune medications, so that those immunosuppressive medications we're going to use for these patients. There's a drug classification for rheumatoid arthritis. They are known as DMARDs, which stands for disease-modifying anti-rheumatic drugs. DMARDs are typically used in combination with NSAIDs, which is non-steroidal anti-inflammatory meds. So a lot of times they're used together. DMARDs are usually pretty effective. They do have, some of these have pretty significant side effects. One of them is the Plaquenil, which you've seen before in the treatment of lupus. It's a DMARD used for rheumatoid arthritis. It's also known as hydroxychloroquine. This drug has the side effect of causing blurred vision. It can cause retinal damage. So if a patient is taking that drug, you would want to encourage them to have an eye exam frequently and make sure they're following up with an eye doctor to make sure that they're not experiencing any retinal damage. They need to report any change in their vision immediately. Methotrexate is a very common medication used for rheumatoid arthritis. It's an immunosuppressive medication that takes a while. It takes about 4 to 6 weeks to begin to control the inflammatory, to decrease the joint symptoms. So with this drug, we're going to monitor the patient for effectiveness. It's going to take 4 to 6 weeks to take hold, so we're going to monitor them the whole time to see if it's working for them at all. If they're on this medication, they're at risk for infection. They need to avoid crowds. They need to avoid drinking alcohol because it does have a tendency to cause liver toxicity if they combine it with drinking alcohol. They need to report any side effects such as mouth sores or pneumonitis, which would be acute dyspnea. So it has a lot of very kind of severe side effects. They're kind of rare, but they are severe when they happen. So they need to be educated. The patient needs to be educated well on what they need to report. Definitely they should not become pregnant while taking methotrexate if they're at risk. They are not going to be able to take the methotrexate. They need to have a strict birth control process if they're going to be taking this medication. If they ever want to become pregnant, they'll have to talk to the rheumatologist on how that's going to work. So DMARDs, NSAIDs are the drugs of choice for patients who have rheumatoid arthritis. Again, we understand the side effects of NSAIDs can be that GI upset. They need to report any GI pain and GI problems, any black tarry stools. Other NSAIDs that are out there, Celebrex is the brand name. It's Celecoxib. It's a COX inhibitor. It's an NSAID in that classification. It does have some known side effects that can cause cardiovascular disease, such as myocardial infarction. And some of these have been taken off the market. I believe Celebrex is still available, but it's just something you wouldn't want to give somebody who already has a cardiac history. And if they don't have a cardiac history and they decide to give it to them, they're going to monitor them closely for any signs or symptoms of cardiovascular disease. You have a nice table on page 338 and 339 in your book that outlines NSAIDs and also the DMARDs, the treatment for rheumatoid arthritis. So make sure you review those. Nursing care for a patient with rheumatoid arthritis. There are some non-pharmacological interventions that we can assist with for a patient with rheumatoid arthritis. First of all, we want to encourage adequate rest, proper positioning. Application of heat and ice can also help with pain management. Again, you got to want to make sure we educate regarding the safety of using these modifications. There's other things that can be applied to the joints. It's something called heated paraffin wax dips. Helps decrease the pain, and it's the warmth on the arthritic hands. Again, it would have to be done under lots of education and safety. Finger and hand exercises are often done to help after the paraffin treatment. So after the warmth is applied, then they'll do some exercises to loosen the joints up. Morning stiffness is a very big issue with these patients. It's hard for them to get up and get moving. Recommendation is that they take a hot shower rather than a sponge bath in the morning. Basically what that does is it warms their joints up and it helps them to get moving quicker. It's hard for them to get it out of the bathtub anyway, so a warm shower is going to be like an ideal thing for them to do in the morning to warm up their joints to decrease that stiffness. Hot packs applied directly to the joint may be beneficial, again with safety thought in mind. Physical therapy always is a good interdisciplinary team to pull in with these patients. They can recommend lots of different non-pharmacological treatments for these. Relaxation techniques can help them. Acupuncture and hypnosis have been known to help some patients with their chronic pain related to rheumatoid arthritis. Adequate nutrition is always required or recommended for these patients. Should avoid obesity, as obesity is only going to cause more wear and tear on the joint. So it's better if they keep a good, they want to have adequate nutrition, but they also want it to be smart nutrition. So lots of, more vegetables, more fruits, a healthy diet is going to be the best thing for them. The inflammatory response for these patients is going to increase their metabolic burden, so they're going to need to make sure that they keep up their calorie intake so that they don't, if you recall, we said that these patients have a tendency to lose weight, and it's usually because of the increased metabolic burden related to the inflammatory response. Natural recommendations for these patients, if it's not contraindicated by any other disease processes, is calcium supplements to prevent bone loss. Cold water fish or fish oil capsules containing omega-3s. This is thought to reduce the inflammatory response. It is a thought that no food causes or cures rheumatoid arthritis. However, healthy nutrition is generally supported. So focus areas here regarding nursing care that I want you to make sure that you look through. Starting on page 3 41, it talks about promoting self-management. What as we nurses, as healthcare workers, can do to promote self-management? These patients want to stay independent as possible for as long as they can. There's a lot of things that we can get them, tools to help them remain independent. Managing fatigue is also a piece that we want to be able as nurses to kind of help them do and help them work through and educate them about. There are specific energy conservation for a patient with arthritis. Page 342, chart 2010, talks about how to help them preserve energy. Enhancing body image is another priority for the nurse to kind of help the patient with rheumatoid arthritis work through and understand. So make sure you read through all of those. Also, home care management is another job of the nurse to make sure that they get what they need at home. Maybe it's an elevated toilet seat. Maybe it's rails to hold on to as they get into the shower. Things like that we're going to have to make sure that we facilitate that the patient gets as they are out in the community so that they remain independent. Gout is our final arthritis that we're going to talk about for this presentation. Gout, we kind of know a little bit more about the cause of gout. It's also known as gouty arthritis. It's systemic. So remember those key words in some of these arthritis. So this is a systemic process. And basically what happens here is urate crystals deposits in the joints, causing inflammation within the joints. Very, very, very painful arthritis. The patients I've seen with gout, they won't even let you near their joint that's all inflamed. If you barely touch it, they'll scream. It's very, very painful. Two types of gout are known. Primary is the most common, of course. It's a type that results from patients or just have a genetic disposition to have an error in their purine metabolism. So what's important to know here is the end product of purine metabolism is uric acid, and that's usually excreted by the kidneys. In gout, the production of uric acid exceeds the excretion capability of the kidneys. So it's deposited in the synovium of these joints, and it builds up in there, and it causes inflammation and causes a severe pain. So it's thought to be an X-linked trait. So males have it more than females. So it tends to definitely run in families among the males. Secondary gout is thought to be related to hyperuricemia, which is excessive uric acid in the blood. So, and it's usually caused by another disease factor. So our questions to determine about a patient with the signs and symptoms of gout: is it primary, is it secondary? The next questions: is it acute or chronic? You're going to see acute gout much more than you'll see chronic gout in the United States. So to review, gout is a systemic disease in which urate crystals deposit in joints and can be in other body tissues. Primary gout results from a disorder of purine metabolism. So it's a metabolism issue. Secondary gout involves excessive uric acid in the blood caused by some other disease. This is a picture of how the uric acid builds up in the joint. This is a common site, the great toe, for patients to have signs and symptoms of gout, is in the great toe joint. And you can see how the uric acids can cause that inflammatory response and cause a lot amount of pain. Signs and symptoms of gout include swelling and inflammation of the joints, leading to excruciating pain. There's going to be something called tophi, which is nodules on the skin. They're hard, irregularly shaped nodules. Low-grade fever, they can have headache. And they can also get like an itching on the skin from the urate crystals build up in the skin. Treatment for this: basically the patient, if they have primary, which is mostly what we see in the United States, we need to put them on a low purine diet, because that will, if they can't metabolize it correctly, then they need to eat just a little bit. They shouldn't eat very much of the purines at all. Purines are typically found in organ meats, wines, and aged cheese. It's typically in a lot of processed food, so they need to stay away from it. High fluid intake. is another that can help the flow and keep the purine washed from the kidneys. So basically just kind of dilute it down and have and that helps just the flow and the metabolism, the high fluid intake. Instruct the patient to avoid alcohol because they can precipitate a gout attack. Some alcohol has high purine in it and can exacerbate a gout. Provide bed rest during attacks. Want to protect the joint that's affected during an attack of gout because it's going to be, like I said, extremely painful. They can sometimes do heat or cold to it. Sometimes it's too painful to apply, something like that too. There are specific anti-gout medications that we can give that reduce the uric acid production and increase uric acid excretion so that it decreases the symptoms of gout. Those are known as allopurinol, colchicine. Those are anti-gout medications. So basically they work by reducing that uric acid production and increases the excretion of it. You can give them NSAIDs, non-steroidal anti-inflammatory drugs, to help with the inflammation in the joint, and that can decrease the pain. Glucocorticoids may be prescribed if the inflammation is so much that it's causing a lot of difficulty moving the joint and pain in the joint. So make sure you review the diet. There's a couple slides after that kind of go over the diet that is encouraged for a patient who has gout. Again, they need to avoid those foods that have high purine levels in them. One thing to take note of as far as anti-gout medications, if they are taken with aspirin, it can cause an elevated uric acid level. So the client should be instructed to take something like acetaminophen or Tylenol for pain rather than aspirin. Or you have those patients that are taking aspirin for cardiovascular risk, so they really need to talk to their doctor about if they're taking anti-gout medications and aspirin. It actually could elevate their uric acid levels, so they need to have that conversation with their physician. So summary of nursing care for a patient with gout is monitor that fluid intake, make sure they have adequate fluid intake of at least 2,000 to 3,000 milliliters a day to prevent kidney stones, because uric acid levels built up in the body can cause kidney stones as well. It also helps the kidneys. Monitor their complete blood count, renal and liver functions. They have to avoid alcohol, caffeine also. These products can increase uric acid levels in the body. Wine is one that is known to be high in purine, so they need to avoid that. Sardines, salmon, scallops, gravy, those all have high purines in them. They need to avoid them. This slide is just a visual picture of all the things that a patient with gout should avoid because they can trigger a gout attack. And this concludes the presentation for Nursing 150, Module 4, regarding rheumatoid arthritis, osteoarthritis, and gout.